The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome. Glad to have you here. Hope you can learn something today after we talk a little bit about the topic. I am Tony Urbanek, and this is TMD Demystified. Today's title of this episode is Observe the Obvious and TMD. Observe the Obvious and TMD. Observe the obvious. What does that mean? It means exactly what it says. Observe something that's obvious. See it for what it is. Acknowledge it. Don't argue with it. It's there, okay? So we're going to talk about how TMD got sidetracked, misdirected, combobulated, because the dentists who try to treat this, the scientists who try to come up with a solution, the different generalists and specialists refuse to observe the obvious and then follow that obvious direction. That is why for the past 70, actually 90 years, TMJ, which everyone calls it TMJ, of course, everybody has two TMJs, Temporomandibular Joint Disorder, singular. It's not multiple disorders. It's one disorder, which we have discussed many times. TMJ disorder is something that could have been solved 90 years ago if the profession of dentistry had begun to observe the obvious. And I will explain. And hopefully within the next few minutes, it will make sense to you, because my job is to teach and make sense about this problem, conundrum, called TMD. So again, historically, TMD was first noted, identified as some kind of problem by Dr. James Kostin in 1934, who was an ENT surgeon out of St. Louis, Missouri, who wrote on this syndrome, who wrote an article on this syndrome of jaw pain and neck pain and headache that he associated with a joint problem, joint damage. And for the next 20 years, that syndrome, which was noted as a TMJ syndrome, was called Kostin Syndrome. And in the 50s and in the early 60s, it began to have its own nameplate, and it was just called TMJ, which confused everybody because TMJ, temporomandibular joint, is just the name of the joint. It's like going to the orthopedic surgeon and announcing you have knees. But everyone walks into a dentist's office and says, I think I have TMJ. It's humorous, but true, and that solidifies how confused everyone was and is about the problem. To this very day, most dentists, most physicians, most patients, almost all, still call the problem TMJ. All right, so that's a little history. And now, beginning in the 1960s, we had the dentists and the dental schools who were burdened, literally burdened, by this problem called Kostin Syndrome, TMJ, to figure out a way, because the medical doctors, the ENTs, the orthopedic surgeons did not want anything to do with treating this joint because it had to do with teeth. this joint is a joint for the jaw, which is attached to the teeth. And the other medical doctor said, no, I don't want anything to do with this. There's teeth involved here, and the dentist must know about this, which they didn't, obviously, because it hasn't been figured out until very, very recently by yours truly. So in the 60s, we began to see the general dentist and the dental specialist take a lick at trying to solve this problem, but they did not try to do it thoughtfully or scientifically. They basically just used the method of whatever the method of, if you have a hammer, everything looks like a nail. So if you are a general dentist, what general dentists do is work on teeth. So they kind of configured manners to address the problem by working on teeth. The orthodontists considered and developed treatments by moving teeth, and the oral and maxillofacial surgeons, of which I am one, developed many surgical kinds of treatment directly on the temporomandibular joint surgically to try to solve the problem. I don't want to come across as overcritical, but I have to speak the truth about exactly how all this came to be, why it has not been solved, and actually how I developed the information and put it together so there is an obvious solution to this problem. And it began with observing the obvious, observing the obvious. So the general dentist, and some of you who are professionals, dentists, dental hygienists, physicians, or many patients, as I find out, listen to these podcasts, these episodes. You are familiar with the dentist equilibrating teeth, making the bite better, taking out high spots on the occlusion. It's called equilibration, in an attempt to fix temporomandibular joint problems, because the theory behind that was if you have interferences with the bite, it overloads the joint, causes damage, which is true. If you overload a joint, whether it be a knee, a hip, an elbow, if you overload a joint, it will become damaged, and the damage obviously causes symptoms. But the general dentist used equilibration, sometimes very, very sophisticated equilibration, grinding on teeth, take off high spots and interferences, in an attempt to treat TMD, because one of the things that is obvious about TMD is that in a lot of patients, it is associated with people who brux or clench and grind their teeth. So we do not have a solution to stop clenching and grinding. In fact, we do not even understand the mechanism for clenching and grinding within the central nervous system. All we know about clenching or grinding, it is related to bruxism, and bruxism is related to temporomandibular joint disease. That is a fact, and that is literally a fact by way of observing the obvious. And half the population in the United States of America bruxes their teeth, clenches or grinds to some degree or another. Not all of them develop temporomandibular joint disorder, but the general dentist felt that equilibrating the teeth would assist in partially unloading the joint and therefore decreasing damage, therefore decreasing symptoms. Not a bad theory, but it was just the theory. And there are still doctors who do that, equilibrate the teeth to try to decrease TMD symptoms. General dentists also learned in dental school, and still do, that the approved usual treatment for TMD is the construction of a night guard, basically a plastic tray that goes over the surfaces of the teeth, not unlike an aligner, just a little stiffer and thicker, very similar to an orthodontic aligner, as the treatment. And today, in 2025, half the dentists in the country, if they are confronted by a patient with TMD, will make a night guard, give it to the patient, and basically hope the patient doesn't come back, because they know that night guards don't treat TMD. And there is recent literature coming out now agreeing from the dental industry, the dental profession, that night guards do not treat temporomandibular joint disorder. But you consistently will find dentists who make night guards. The orthodontist took their turn at this by attempting to, similar to the dentist, moving teeth to take out interferences so the bite would be more natural or fit together well. Not a bad theory. Interferences of the teeth can exacerbate bruxism or exacerbate temporomandibular joint symptoms, which is observing the obvious also. But the problem is orthodontics by itself is not effective in treating the plethora of symptoms associated with temporomandibular joint problems, which include frequent and/or recurring headaches, earaches, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, that feeling of fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Those are the accepted symptoms of TMD, and orthodontics alone will not fix those symptoms. And then finally, the oral and maxillofacial surgeons, of which I'm very familiar with, because the first 36 years of my career had a large focus on treating temporomandibular joint problems by doing temporomandibular joint surgery. And over that 36-year period, I did well over 2,000 temporomandibular joint cases, half of them open joint, meaning incision in front of the ear, going into the joint and doing various things and removing various things and doing various things to reconstruct the joint. And half of those surgeries were done through an arthroscope. And each and every one of them was proposed by the oral and maxillofacial surgery profession. And what I found after 36 years and 2,000 cases, that a third of my patients would be back within a year or two with the same symptoms I tried to address with surgery. And that is why I began a focused effort to do the research to find out why no one could figure it out. And I could not address new patients knowing that a third of the patients would be back within a year or two with the same symptoms. And that's when I decided I wasn't going to do any more TMJ surgery, and I was going to see if I could figure it out. So those 2,000 cases included every kind of surgery. There is no surgery that really stands out in correcting predictably 100% of patients, or even close to it. We had 2/3 of the patients did very well, and I still have patients come back after 20 or 30 years with one side that we operated on doing very well and the other side now giving them symptoms. I have a whole file of that. But the point is, I could not face a patient and tell them I was going to fix them like I did with other types of maxillofacial reconstructive procedures that I did: cleft palate reconstruction, orthognathic reconstruction, cancer reconstruction, that microneural reconstruction, that I could say, if we do this surgery, this is exactly what will happen. Couldn't predict that in temporomandibular joint surgery. But, and this is the point of this presentation, this episode, there is something that treats the temporomandibular joint successfully, predictably, 100% of the time, which was overlooked by the profession as a starting point to address the problem. And that is the fact that non-steroidal anti-inflammatories, basically aspirin or ibuprofen, or naproxen, are non-steroidal anti-inflammatories. And if you have an early case or a recent, let's say recent case of TMD symptoms, using one of those three drugs or combination of those drugs will decrease the symptoms consistently, but only for a short period of time. They run out of steam, and they run out of steam relatively rapidly. Again, observing the obvious, patients and doctors, I've never discussed this with a patient or a doctor, and have done so with hundreds and hundreds, if not thousands of them, about this issue. Non-steroidals work really well for a short period of time. No one disagrees. Not the patients, not the doctors, not the physicians, not the dentists. Non-steroidals work really well. And non-steroidals, what do? They decrease inflammation. But why then, if you know that decreasing inflammation with non-steroidals works so well, but only for a short period of time, did not the scientists, researchers, clinicians look to something else that would decrease inflammation over a longer period of time? Well, my journey started with patients who actually, when I interviewed patients and began to do the research, starting with the patients themselves, when they said, if I put up my tongue, my finger, a pencil eraser, a small piece of cloth between my front teeth and bite down, it feels better. I began to research that point of view, that topic, that statement from the patients consistently. 12 out of 24 patients, the first 24 patients, 12 of them said, if I put my finger or pencil eraser between my front teeth and gently bite down, it feels better. I made a device that went between the front teeth that they could speak with. You could talk well with it, you're comfortable with it. It's very inapparent, it's not obtrusive, and you can wear it for a lengthy period of time. And I gave it to the first lady who had this symptom, and she came back in 3 weeks and said her symptoms were gone after 20 years of headache, earache, jaw pain, neck pain. That is where the process started. Then it took 20 or 30 more cases for me to figure out. I didn't know really the mechanism that was going on, the mechanism involved. And that took very little time to figure out that what you're doing when you do that, you separate the back teeth and unload the joint. 90% of the load on the temporomandibular joint comes from the posterior teeth. But you can't separate the posterior teeth indefinitely. That will cause dental problems. That will cause the teeth to shift. That will create problems. So a protocol was invented, protocol to use this device, which is easy to see, easy to use, and the protocol is 24/7 for 2 months, nighttime only the rest of your life. 24/7 for 2 months, except when you eat. You got to take it out to eat. Take it out to eat. After you eat, you brush your teeth. You brush the device with toothbrush, toothpaste only. Put it back in your mouth. That goes on for 2 months, and nighttime only indefinitely. That handles 85% of the patients, and a few patients, 15%, find they need to wear it a little more during the day, and they come in and attest to the fact that they figured out when they're sitting in traffic or they're sitting on the computer, clenching their teeth, they've learned to put it in, which solves the other 15% of the patients. So 85% of the patients at 24/7 for 2 months, nighttime only the rest of your life, works extremely well. And then 15% find under times of stress, they put it in. But you have to be consistent. You have to be consistent. And unloading the temporomandibular joint using that device and protocol is exactly what a set of crutches does to a knee, or a sling does for an elbow. In fact, tennis elbow and TMD are the same disease, just different joints. Tennis elbow and TMD are the same disease, different joints. One's called tennis elbow and one's called TMD. But the inflammation in the joint creates all the symptoms. Please refer to prior episodes of me describing how that happens. It's well described in other episodes that I've talked about and presented. But the point of this episode is observing the obvious. So we, the doctors and scientists who have tried to treat and find out about the conundrum of TMD and the disparate symptoms and how they are related, did observe some obvious facts. One of the facts is that anxiety stress creates bruxism. That was a method of observing the obvious. But observing the obvious that non-steroidals actually decrease inflammation and they work really well was not followed up, was not thought of as important. But non-steroidals work really well. What do we have? What can we develop or have as a replacement for non-steroidals that would work over a long period of time? And that is unloading the joint. And how do you do that? You use a device and protocol that separates the back teeth over a period of time. It's a very important protocol because you can't, if you separate the posterior teeth more than 2 months, you will start to see super eruption, movement of the teeth that are going to create occlusal problems. Don't want to do that. And that fact is true only in adults. In children, you have to be much more careful using this protocol, and it's adjusted for children. In children, as soon as the children find that their symptoms decrease, diminish, or gone, then you take them out of the 24/7 and continue the nighttime only protocol. That's the gist of it. So observing the obvious, it is a method to develop answers, brings solutions to problems. Nothing wrong with observing the obvious. And in this case, observing the obvious that non-steroidals actually did a really good job of treating this disease, but only for a short period of time. Why the profession did not follow up on that for 90 years, I have to scratch my head, because when I began doing the research, it became obvious to me, observing the obvious, that that was the direction we needed to look. It became obvious, observing the obvious, that the direction to solve the problem of TMD was simply solving inflammation within the temporomandibular joint. And again, how inflammation creates each and every one of those disparate symptoms, you can look at other episodes. I won't go into that. We spent enough time on this issue today. With that said, I look forward to the next episode I create about TMD Demystified, bringing sanity and knowledge and science into the treatment of TMD rather than confusion and misunderstanding, misdirection, mistreatment, misdiagnosis, that has been the hallmark of doctors who have been trying to treat TMD for the past 90 years. With that said, I am Tony Urbanek, and this is TMD Demystified.